During the end discussion, please use the microphones to ask questions. This year, we'll also be live broadcasting our post-grand round interviews with Dr. Blumenthal, and I will go live at 9:45. And if you had like to submit a question, we have flyers at the back of the room with instructions. And also, we just wanted to give you an update on two conferences that will be holding. One is the third annual Heart of a Woman on February 5th, and the 10th annual multimodality cardiovascular imaging for clinicians, March 14 to 16 at in Florida. So just to start, it's truly a special honor for me to introduce my eternal mentor and friend. And if not for him, I would definitely not have the privilege of being here today, and many others around the world to be in a position impacting lives as preventive cardiologists. So let me be brief. He's the distinguished Kenneth J. Pollan Professor of Cardiology and Medicine, and the director for the Johns Hopkins Ciccone Center for Prevention of Cardiovascular Disease in Baltimore. He received his medical degree from Cornell Medical School, did his internal medicine and cardiology fellowship at Johns Hopkins, and stayed there since then. He's the principal developer of the prevention program at Hopkins, now rightly called the Mecca of preventive cardiology. Now, as preventive cardiologists, everything we do, Roger has impacted that. As far as I know, he was the co-chair of the ACC-AHA guidelines on cholesterol management and blood pressure, as well as the primary prevention. Now, one thing that pleases me the most, apart from receiving so many acknowledgments, that he was the 2019 SCCT recipient of the Arthur Egerton Award, another mentor of mine, very near and dear to me. So Roger, really having the privilege of working with you for the last 19 years, as I was thinking yesterday, I think we can easily claim to say that you may be the founding father of modern preventive cardiology, because you've taken away from a very lipid-centric view of how preventive cardiology was practiced to one that has broadened it to a combination of precision medicine and population health. And not only that, you have inspired and trained so many of the next generations of the preventive cardiology to carry on the gospel. Some of my colleagues and friends at Hopkins, such as Mike Blaha, Seth Martin, Aaron Mikos, Samya Mora at Harvard, Parag Joshi as UT Southwestern, Susan Gilchrist, our own at MD Anderson, and Bill McCoy spreading the message in Ireland. So although there are many who had played a big role in bringing back, and which was considered a niche specialty in the 90s to become mainstream and an integral part of cardiovascular disease management. However, I think there is a complete consensus on who has played the biggest role, and that's definitely our speaker today, Dr. Roger Blumenthal. So please give him a big welcome to Houston Methodist DeBakey Heart and Vascular.
Well, Khurram, thank you very much. It's an honor and pleasure to be here. Khurram is one of my closest friends. It was great last night to have dinner with Dr. Zogby, Moaz, Glenn Levine, who headed up the task force on the great set of guidelines over the last few years, and Peter Jones, a longtime collaborator. It's a pleasure to be here. So I'm going to try to give you a sort of unique perspective, a little bit of Baltimore twist. As Khurram mentioned, our preventive cardiology program is named the Ciccone Center for Prevention of Heart Disease. And Henry Ciccone was a close friend of mine. I went to college at Hopkins, assistant sports information director. Henry Ciccone was a legendary coach, previously a great athlete. But he had a massive heart attack in 1986 and then did everything right. He had sort of a metabolic syndrome type profile, had been a smoker, high stress job. Think of a combination of Irvin Meyer, Mike Krzyzewski, Gary Williams, very high energy kind of coach, but did everything right. And then a year later, he and I were supposed to play in a member guest golf tournament, started developing chest pain, went down to Hopkins, and another artery was narrowed. First, it was the right coronary artery initial heart attack, then a circumflex marginal. again, redoubled his efforts, doing everything right in around 1987, and then he had sudden cardiac death in 1988. And I'd always wondered, how could we do a better job of predicting who was really at higher risk? And you may remember that 1987 is when the first statin came out. But when that came out, we were sort of thinking about very high LDLs, not the metabolic syndrome type profile like Coach Ciccarone had with the higher triglyceride, lower HDL. And you know, it's a stressful thing being a lacrosse coach. This is a picture of Coach Ciccarone, Hopkins, Maryland game. The assistant coach, Joe Cowan, looks like he's going to punch out one of the referees. You would have thought that maybe he was more of a candidate for a cardiovascular event. But we've learned a tremendous amount since 1988 when Coach Ciccarone died. And our centers has a great group of folks. Khurram Nasir has been instrumental in our work. But I'd like to say that, and Khurram's been a tremendous mentor to all the folks here. And preventive cardiology is really focused on the prevention of coronary artery disease, now heart failure, now atrial fibrillation, now peripheral arterial disease. And I think, Khurram, what we need to add is cognitive decline, because there's such great data that better blood pressure control and lifestyle management can help so much. And you may notice, what is this funny little logo here? This is a blue jay with a lacrosse stick, a stethoscope, and a headlamp. That's been the symbol of the Ciccarone Center. So let me take you back in time, 2013 here in Texas and Dallas. They present the great cholesterol guidelines. And on the front page of the New York Times and other newspapers, there was some controversy about those guidelines. And some misconstrued the guidelines and said they were simply fire and forget. You give 20, 40 milligrams of atorvastatin, that's all you need to do. But that really wasn't the case. The guideline actually mandated ongoing lipid monitoring to assess adherence, treatment response, and need for altering therapy. And other people said, well, if you're above this 7.5% 10-year threshold of a heart attack or stroke, it mandated a statin. But in reality, the guidelines said it mandated a risk discussion, and that sort of got lost with the controversy about the risk calculator and how accurate that really was. And one of the things was that they sort of took away numbers, and patients and physicians are used to having numeric goals like A1C, free T4, uric acid levels, you know, for cardiologists, SAT and MCAT scores, GPA, for the golfers, golf handicap in the single digits, and since I play a lot of tennis these days, percent of first serves in. We sort of thrive on numbers, but it seemed like those 2013 guidelines took that away. And I had the pleasure of working with Dr. Levine and a lot of these guidelines, and Mariel Jessup. We were the co-chairs to try to work on those blood pressure and cholesterol and risk assessment guidelines. And I think one of the keys was Sid Smith, who was the mainstay of the 2013 guidelines. And Glenn, you'll have to tell Sid that he can really sky. He was a pretty darn good leaper. Maybe Roy Williams should have him come off the bench sometime. But I was a little bit surprised when the ACC and AHA reached out to me, because, you know, with Khurram, we were involved in several articles in JACC that were high profile, and it didn't really win me some friends from the prior guideline committees. One was what was done well and what could be done better, led by Seth Martin, and one that especially raised the ire of some of our friends with the prior guidelines that Khurram remembers well was an article that we wrote called Headed in the Right Direction, but at Risk for Miscalculation. And one of the prior guideline authors, I think, wrote me a 6-page, single-space letter. I think it had something to do with my mom and maybe my grandmother. I can't remember. But suffice it to say that we were able to diffuse some of that, and I think the last set of guidelines was much better. So let's talk about the take-home messages first of the 18 guideline, because it applies to everyone in this room, whether you're internal medicine, cardiology. So first was emphasize a heart-healthy lifestyle. It reduces risk factor development. We also talked about the importance of assessing lifetime risk. It facilitates that risk discussion. And by emphasizing lifestyle efforts, that's the best way to prevent prediabetes and diabetes itself. Then we said if you have clinical atherosclerotic disease, you want to reduce LDL with a high-intensity statin, or if you weren't tolerated that, we would try a maximally tolerated statin. The more LDL is reduced, the greater the risk reduction. And we emphasized that you wanted to try to get an LDL reduction of at least 50% with a maximally tolerated statin. We then said if you were very high risk, let's say you were one of Dr. Levine's patients down the street, unstable angina, came into the CCU, that very high-risk person, multiple events or one major event and high-risk conditions, we said it was reasonable to add ezetimibe to the maximally tolerated statin if the LDL remained above 70. And then adding a Pcsk9 inhibitor was reasonable, but we said the cost effectiveness was less certain. Because back then, the prices, as you may remember, were $14,000 plus. And Khurram led some great investigations to show that was just much too much to ever get to a cost effectiveness. Then we said if you had severe primary hypercholesterolemia, many of these patients would come see Dr. Jones over the years down here in Houston, that we wanted to get you down to an LDL below 100, and if we couldn't do it, then adding ezetimibe was reasonable. And then we said if you were still above 100, then consider that Pcsk9 inhibitor. Well, this was a hotly debated topic here, and one that I actually disagreed with, and a lot because of the research I'd done with Dr. Nasir and Nathan Wong and others. But we went with the attitude that if you were 40 to 75 with diabetes, then we should start off with a moderate intensity statin. And they said if you had multiple risk factors, especially if you were older, 50 or older, it's reasonable to go ahead with a high intensity statin. And actually in the MESA study, what we found is that about 37% of the type 2 diabetics actually had no coronary artery calcium and had extremely low risk over the next 10 years. But I didn't win that argument in the guideline committee, just like I don't win a lot of arguments in my own home. And this is some of the data where I thought, the data that Khurram and Nathan Wong had put together, I thought was pretty compelling. Adults with diabetes, we had 888 individuals, and 37% had no coronary calcium, 11 years of follow-up, and the diabetics are here in these light bars, and you can see about a 4% event rate of coronary heart disease over the next 11 years. And personally, I think if a person with type 2 diabetes is statin adverse or really wants to work hard on lifestyle, that's fine for me. I think we may go 4 months, 6 months longer, but our guidelines really said all diabetics are at such high long-term risk that we probably should have them on statin therapy. Number 6 was that in people evaluated for primary prevention, we wanted to do a clinician-patient risk discussion. We talk about their 10-year risk. We talk about any risk-enhancing factors that we'll go over in a little bit. And we had emphasized that patient preferences are the key thing. It's not that physicians are mandating what a patient should do. The patient is the one who makes that final decision. We said that risk-enhancing factors should be used in shared decision-making, but if the risk status remained uncertain, we should consider a coronary artery calcium scan. And so much of this is due to the great work of Dr. Nasir, Dr. Blaha, Dr. Budov, that we'll talk about in just a little bit. Well, what are these risk-enhancing factors? Well, we categorize them as a family history of premature disease, a persistently elevated LDL, metabolic syndrome. We brought back chronic kidney disease into the guidelines. We introduced a number of factors pertaining to women like preeclampsia, premature menopause. We also made an emphasis on chronic inflammatory disorders. If you had rheumatoid arthritis, lupus, advanced psoriasis, or HIV, those things might sway you to starting the statin earlier. We talked about high-risk ethnic groups, South Asian, maybe Native American, and persistently elevated non-fasting triglycerides. All these things might sway you to starting a statin earlier, in addition to working hard on lifestyle. Well, recently, some of you may have seen the European guidelines, and they are very good. They have a number of other what they call risk modifiers. They talk about social deprivation. They mention obesity, increased psychosocial stress. They also talk about major psychiatric conditions, schizophrenia, depression, and they also add in atrial fibrillation, LVH, sleep apnea, and non-alcoholic fatty liver disease. All these things might sway you to starting statin therapy earlier. Well, keep in mind that just because you have a risk-enhancing factor doesn't mean you're at high risk. And a number of studies have shown that you may have rheumatoid arthritis, middle-aged, 60% of those people had no coronary calcium, extremely low event rate over the next 7 to 10 years. A large HIV study, about half had no coronary calcium. in a large study on people with psoriatic arthritis, nearly 60% had no coronary artery calcium. So keep in mind, just because you have one of these risk-enhancing factors doesn't mean you necessarily are at high risk and need to be on statin therapy. The guidelines said that you didn't have to measure these special blood tests, but if they were measured, these things could also be considered as risk-enhancing factors. A high ApoB, a high CRP, an ABI less than 0.9, and a high Lp(a). And again, Dr. Jones has led some of this great work on Lp(a). But again, not everyone who has these factors is at high risk. So here's a little question I posed at the AHA. Maybe we can have sort of a show of hands. If a MESA participant not on statin therapy had 3 of those risk-enhancing factors, the prevalence of a coronary artery calcium score of 0 was. And I would say, how many people would, less than 10%? Any show of hands? Should be pretty reassuring. 10 to 39%? 40% or higher? Well, actually, folks, it was around 45% of the people who had 3 or more risk-enhancing factors. They had no coronary, and about 45% of those individuals had no coronary artery calcium and were extremely low risk over the next 10 to 12 years. Well, number 10 of our take-home messages was that if the decision was uncertain, consider a coronary artery calcium scan. So how do you do that in practice? Well, if you have no coronary calcium, the statin may be withheld or delayed. We said except in cigarette smokers, maybe because of prothrombotic. We said those with diabetes, though I wasn't too sold on that, and those with a strong family history of premature disease. Again, something that I didn't agree with because Khurram and J.D. Patel and Bill McAvoy had already published data from MESA saying that all those people in MESA with a family history of premature disease, it was only those individuals with a high coronary calcium score that had events. If you had no coronary artery calcium and you had a family history, your event rate was exceedingly low. And if you clearly had moderate coronary calcium above the 75th percentile, we said the data was really clear that a statin was indicated, and we even said having mild coronary calcium favored a statin. And then I'd add in 10A here, that you want to assess adherence and percent response to LDL lowering therapy and lifestyle changes. You needed to repeat the lipids 4 to 12 weeks later after a treatment initiation or dose adjustment, and then repeat it as needed, whether it's 3 months, 6 months, 12 months. You wanted to look at the percent LDL reductions, and we also brought in the Martin-Hopkins equation. One of our colleagues, Seth Martin, along with Steve Jones at Hopkins, had shown that the Friedewald equation loses a lot of its accuracy when the LDL is low or the triglycerides are high. And let me just sort of show you this great study that Seamus Welton did evaluating the atherogenic burden of individuals with a Friedewald estimated LDL less than 70 compared to the novel estimation method. That essentially 20 to 25% of the individuals who had a Friedewald LDL less than 70 actually had an LDL significantly above 70 when you did this newer estimation. And Quest Labs has adopted this. A number of labs across the pond in Europe have adopted this. The Hopkins lab does it. And keep that in mind. So you might say if these numbers like 70 are important, 100 is important, 50 is important, that the Martin-Hopkins equation is a more accurate estimation of what the true LDL is. So let's go back to what I like to call the ABCs of prevention. We've got to make this simple, especially for primary care, because they have so many things that they have to keep in mind. And even in cardiology, it's so hard to keep up with all the different specialties. But keep in mind that the ASCVD risk score is dominated by chronologic age. Khurram and I have written paper after paper after paper showing that whether it's the Framingham score, the ASCVD risk score, has many limitations. And I like this cartoon that Mike Blaha likes to show that says, you're 57 years old, I'd like to get that down a bit. So the next thing I wanted to show you is that my pointer's not working up here. I don't know, in the back, it looks like the screen is going down, but A for risk assessment. Right now, we say we're trying to predict MI or stroke, but I think in the future what would be better, especially for primary care, is to say, what's your risk not only with MI or stroke, but also heart failure, AFib, revascularization. Because many times I tell patients they have a 15% risk of a heart attack or stroke, and they say, Doc, 85% chance I'm not going to have an event. I don't think I need to do anything. But if I added in heart failure, AFib, revascularization, I told them they had a 50% chance of one of those events over the next 10 years, then I think that would get their attention a little bit more. So what do you need to know about coronary artery calcium? Well, calcium is a marker of subclinical atherosclerosis. Work from Mason, a lot of what Dr. Nasir, Dr. Blaha, and others have shown is that if you have a calcium score of at least 300, that compared to someone with a calcium score of 0, you're about a 10-fold higher risk with the exact same risk factors. So a high calcium score is very, very predictive. And you can think of it as sort of that type 5 fibroadenoma when you start developing that calcification. I remember distinctly this great paper that Khurram was the senior author on with Mike Silverman. We got lots of pushback from the established risk assessment gurus at the AHA when it was presented. And what we found, and folks in the back there, the pointer doesn't work, if anyone might be able to fix that. But in any case, if the pointer up here doesn't work anymore, it's sort of the screen went down. But what this study shows is that you could have 3 risk factors for traditional risk factors, but if you had no coronary artery calcium on that far right, your event rate was exceedingly low. That sort of went out there. So, okay, perfect. So, appreciate it. So this is one of my favorite slides, and it's a great study perspective that was led by Mike Blaha, Khurram Nasir, and Matt Budoff, and I had the pleasure of joining them. And this is where we sort of talked about the Bayesian approach. It's not the people that come in with chest pain that have a coronary artery calcium where it's very reassuring. It's the asymptomatic person. And I think that's so very important. And this whole concept of the origin of the power of 0 came from 2 papers that Khurram was the senior author on. This was from 2009, where it said an absence of coronary artery calcium in all-cause mortality. And then the conclusion was that the absence of coronary artery calcium predicts excellent survival with a 10-year event rate of about 1%. Why was that important? Well, finding of no coronary calcium could be used as a rationale to emphasize lifestyle therapies rather than pharmacotherapy and to forego repeated imaging studies, namely maybe one of those 1,500 stress nuclear tests for the person with sort of the squirrely chest pain. And I think Khurram and Mike Blaha deserve so much of the credit for what we've done in these new guidelines. Well, this paper that Khurram was the senior author on was probably cited more in our cholesterol guidelines than any other. This was this great paper from 2015, where Khurram divided up the people into individuals who were recommended for statins, 7.5 to 20% 10-year risk, and 41% had absolutely no coronary calcium and were extremely low risk. And then Khurram also looked at those who were that borderline 5 to 7.5% range, and nearly 60% had no coronary artery calcium. And I think it's very helpful for a patient who's on the fence trying to decide, do they want to go on lifelong pharmacotherapy or not, to get a much better idea of what their risk truly is. And then this is probably the paper that was quoted the second most in our risk assessment guidelines and cholesterol guidelines. Again, one that Khurram was senior author on. We're looking at the MESA population. We looked at not only 0 coronary artery calcium, but the absence of carotid plaque, normal ABI, normal CRP, normal BNP, no family history, et cetera. These other factors modestly decreased the estimated risk, but no coronary calcium decreased the estimated risk by 60 to 70%. And it's more reassuring, especially in the older individuals, such as those 60 and older, as opposed to those who were closer to age 50. So the conventional view of risk factors was that you do a blood test, do some genetic tests, and it would increase the risk, and what would we do? We give a medication. But the concept of negative risk factors that Khurram and Mike Blaha have led is say, well, if you have no coronary artery calcium, we could lower your estimated risk by 60 to 70%. We have some time to work on lifestyle factors, and I think that's such a great advance in preventive cardiology. And then when you look at the 10-year event rates in the multi-ethnic study, and Matt Budoff published this paper, that if you had no coronary artery calcium over a 12-year period, less than 5% of the females and less than 5% of the males had an event. So again, very reassuring. It's not 0. It's not a complete warranty, but it certainly helps us, and you can see the event rates are so much higher when you have calcium scores of greater than 300. So Dr. Mikos loves to show this slide, and I like it a lot. So when does she consider coronary calcium scan? Well, in that broad intermediate risk group, 5 to 20%. Maybe people with a family history, they're not sure if they take after the individuals who lived to 90 and or those who had the early premature disease. Maybe the statin-reluctant people, statin-intolerant. Maybe decisions about they can tolerate some statin, do you add ezetimibe, maybe helping decide about aspirin. These are the things that where we think about coronary artery calcium testing. So let's delve into a little bit more about the cholesterol guidelines before we talk about the primary prevention guidelines. What do you need to remember? Well, you want to remember that if you have clinical atherosclerotic disease, a high-intensity statin should be initiated or continued with the aim of at least a 50% reduction. If you had side effects, go with a lower intensity statin and try to get at least a 30% reduction. In the very high-risk individuals, you want to try to get an LDL down below 70. If you still are above 70 with the statin, it's reasonable to add ezetimibe. We gave that a class 2A indication. You might say, well, I thought ezetimibe was out of favor. Didn't the data not look that strong? Well, in reality, we relied heavily on this great paper from the Brigham by Aaron Bahula. And what she did here is to use the TIMI risk score parameters. And if you had 3 points or more, we actually had an absolute risk reduction of about 6.5%, a number needed to treat of 16. But conversely, in the low-risk people, there really wasn't any impact of the ezetimibe. So that's one of the things that I think the European guidelines probably got wrong, since they have a very early use of ezetimibe to try to get that LDL down to an arbitrary number of 55. The actual data says it's only the really high-risk people that significantly benefited from ezetimibe over a 6-year period. So we said if you're very high risk, you could consider the Pcsk9 inhibitor after the maximally tolerated statin and ezetimibe, but you needed to deal with the concepts of cost and the fact that we don't have the 10, 15-year follow-up. So what about the Pcsk9 inhibitors? Again, Dr. Jones has been one of the leaders in this area. If you look at the 4A population, people who had a prior MI, what Khurram and I and Seth Martin wrote the editorial for this paper that Mark Sabatine showed is that those individuals with MIs within 2 years had a much bigger absolute rate reduction than those who had their MI greater than 2 years. If you had at least 2 MIs or if you had multivessel disease, the absolute risk reduction was greater. And especially if you had peripheral arterial disease, that's where you hit the sweet spot. And I'm a golfer. Houston's known for golf. And that sweet spot I thought was good to get in that title. So you want to have those high-risk patients, the ones that you want to think about the Pcsk9 inhibitor first. And then what about Odyssey outcomes? Well, the data suggests that they'll get the biggest bang for your buck when the LDL is greater than 100. And more recent studies have shown it's really the very high-risk people are the ones who derive the greatest benefit from the Pcsk9 inhibitor and Odyssey outcomes. Again, which sort of counterbalances the European approach, which basically is we're going to treat to this arbitrary number in LDL less than 55. Well, what do we need to know about triglycerides? Well, we said you want to first focus on lifestyle factors, obesity, metabolic syndrome, liver disease, hypothyroidism. And then rather than reaching for a fibrate or niacin, we would say that up to triglycerides up to 1,000, it would favor initiation of a statin or statin intensification while we're working on lifestyle. And I think that's very important. And in a few minutes, we'll come back to some of the interesting data about high-dose EPA. And what we said, if you had severe hypertriglyceridemia, a very low-fat diet, avoid refined carbohydrates and alcohol, brought up omega-3 fatty acids and fibrate therapy. But in the past, when many of us trained, we would think gemfibrocil, fenofibrate, and our guidelines are much more statin-centric because that's where the data is. So the issues specific to women, we mentioned the pregnancy-associated disorders, hypertension, preeclampsia, gestational diabetes, small for gestational age infants. All these things might sway you to working harder on lifestyle and starting statin therapy earlier. Well, what about Kidney disease, how did we put those in our guidelines? We said that chronic kidney disease not treated with dialysis or transplantation is a risk-enhancing factor, and that favored initiation of moderate intensity statin plus or minus ezetimibe. And we said if a person is already on dialysis, the data is not very strong, and you could probably avoid statin therapy. Well, in that ABCD approach, we have to remember diet, and it's time for a little bit of humor here. This is someone who has the Pittsburgh newspaper in their hand and says 6 of 10 Americans are overweight, and his spouse put a padlock on the refrigerator door. I think hard to do in practice, but I think avoiding those late night snacks is important. And this nice article in JACC emphasized that we want to focus on reducing excess calories, increase fruits, vegetables, whole grains, nuts, legumes, et cetera. And lifestyle is so very important, and that's what we have to emphasize at each and every visit. Well, let's go to now what the Europeans said. They put down evidence for efficacy of LDL-lowering therapies to below 55. They cited the CTT meta-analysis, they cited IMPROVE-IT, they cited the Fourier and the Odyssey outcome studies, all very reasonable, but they neglected the fact that the lower risk people in IMPROVE-IT and the lower risk people in Odyssey outcomes really had marginal benefit. And that has important implications for cost effectiveness. So this is the best slide. And they say they're very high-risk individuals, B55 would be their target, an LDL of at least 50%. What did they do that's different from the Americans? Well, the ASCVD, clinical is the same, but they also said if you had a carotid plaque of 50% or higher, you had a CT angiogram of 250% stenoses, they'd be aiming for an LDL of 55. They also said if you had severe chronic kidney disease and eGFR less than 30, they would be aiming for extra low values. And they also talked about diabetes, target organ damage, or type 1 diabetes for 20 years, they would go less than 55. And remember, we really don't have the randomized control data to support that, but it's maybe a reasonable assumption. And they said a target of 70 in people with moderate chronic kidney disease and people with diabetes of at least 10 years duration. So there are some differences, and it'll be important to try to look at the cost effectiveness implications of their guidelines and the US guidelines. So let's come back to triglycerides. When we presented our cholesterol guidelines, that's when REDUCE-IT was presented. So who got into REDUCE-IT? Age 45, established cardiovascular disease, or people at least 50 with diabetes and other risk factor, triglycerides between 150 and 500, and your LDL needed to be between 40 and 100. You were excluded if you had advanced heart failure or liver disease. And what got everyone's attention was this massive decrease, absolute risk reduction of about 5% in their primary endpoint. And if you look at the endpoint that a lot of us in cardiology tend to favor, cardiovascular, death, MI, or stroke, the absolute risk reduction was about 3.5%. A number needed to treat of adding high-dose EPA was just 28. And they showed also that if you had triglycerides greater than 250, your relative risk reduction was even greater. Again, very provocative, and as many of you know, the FDA just decided to grant the high-dose EPA a special indication. Well, what about the USA cohort that was just presented at AHA? The absolute risk reductions in the good old US of A is even bigger. Absolute risk reduction of 6.5%, number needed to treat of 15. And if you look at the CV death, MI, or stroke, number needed to treat of 22. Very strong data, and we sort of need to wait to see about the STRENGTH trial with a somewhat different formulation that has some DHA along with the high-dose EPA to find out, why is it just the high-dose EPA? We really don't know. So as we wind up, let me tell you a little bit about our primary prevention guidelines. Thanks to Dr. Levine, he had the foresight to try to put this together in a record 6 months' time, and I had the pleasure of working with Dr. Donna Arnett, and I had a number of colleagues with Hopkins ties on the committee, and Salim Virani from just down the street was an extremely valuable member. So I've always thought, and Khurram and I have worked together a long time, and we say, let's try to make things simple. ABCs, A stands for assessment of risk, A stands for antiplatelet or anticoagulant therapy, B for blood pressure, C for cholesterol or cigarettes, D for diabetes, either management or prevention, diet or weight, and E for exercise and education. And I think it's easier to remember these primary prevention guidelines when you think about that ABC, simple as 1, 2, 3 format. And Dr. Levine, of course, was a great fan of the Jackson 5, so we thought we wanted to dedicate that ABC approach to Dr. Levine. So what are some of the additions to those primary prevention guidelines? Well, we emphasize shared decision-making, and I think patients want to know a little bit more about what their risk really is. We also talked about that team-based approach to prevention. Involve the pharmacist, involve the nurse practitioner, physician's assistant, try to do follow-up phone calls in between visits. We also talked a lot about social determinants of health. You may say, well, what does that mean, Roger? Well, the Medicare had a 5-domain screening tool. People may have housing stability problems, may have food insecurity problems, cannot get healthy food, may have transportation difficulties coming to and from medical visits. Maybe they have trouble paying their utility bills. They may not have a safe place to exercise or walk or go to a gym. These things we have to think about at each and every encounter. Well, for blood pressure, it's pretty darn simple. You got to remember less than 130/80, and from a lifestyle perspective, all these things are so important. Weight loss, a heart-healthy dietary pattern, sodium reduction, increased physical activity, and reduce the alcohol. I don't know if Dr. Welton would like me just summarizing all on blood pressure in just one slide, but 130/80 is what you want to really remember. So the guidelines also talked about that if you had less than a 10% 10-year risk, then you probably wouldn't start pharmacotherapy until the blood pressure was greater than 140/90. But if you had more than a 10% risk, or you had diabetes or chronic kidney disease, the guidelines supported medication at that 130/80 spot. What about C for cigarettes? What do you need to remember? Well, we don't do that well with that, but the guidelines really emphasize using some sort of nicotine replacement in combination with either bupropion or varenicline. And hopefully we can do a much better job in moving forward, but that dual therapy, not just nicotine replacement, not just varenicline or bupropion, but that combination is so very important. Well, what about diet? What did we say? A diet emphasizing vegetables, fruits, legumes, nuts, whole grains, and fish. Minimize the saturated fat and reduce cholesterol and sodium. Those are the key messages that your patients need to remember. We also said you want to minimize the intake of processed meats, things like bacon, sausage, deli meats, decrease those refined carbohydrates and sweetened beverages, and we gave a class 3 harm recommendation about the intake of trans fats. So in terms of trying to get people to get a healthy weight, we emphasize the importance of a more comprehensive lifestyle program, and a formal weight loss program can be very helpful. We want to get people to reduce their calories by 500 a day. We really want them to think about 200 minutes a week of moderate to brisk activity, and we want them to measure their weight. In the office, we'll measure their BMI and their waist circumference. And I think when you measure a person's waist circumference, they realize that that is a really important thing, and they need to try to make some sustained progress. On diabetes, we emphasized again the comprehensive nutritional plan and the exercise, but we also talked about some of the newer medications, the SGLT2 inhibitors, the GLP-1 receptor agonists, that after metformin should be considered. And I think more and more data is going to come out, and they'll be even higher up in our armamentarium. Well, E stands for exercise. I need a little humor now. We're winding up here. And I mentioned about Dr. Levine being a big fan of Michael Jackson. Here's Michael Jackson and Michael Jordan. So exercise could be playing some pickup basketball. It could also be a little bit of dance. Michael was pretty good there. Michael Jordan, not quite as good, but exercise is so very important. So when I presented those primary prevention guidelines at ACC, I said, let's sort of think about hashtags. A stands for assessment of risk, pooled cohort equation first, personalized risk assessment next, refined by coronary artery calcium. For the antiplatelet therapy, we said rethink aspirin. Maybe we might still give it in primary prevention to smokers, people with a strong family history, those with heterozygous FH, very high lipids, people with at least moderate coronary calcium, and maybe those with a really high CVD risk score. B stands for blood pressure. I said 120 is the new 140. Lifestyle first. If high risk, add medicines at 130 over 80. For cholesterol, I said discuss statin if at intermediate risk, refined by coronary calcium, power of 0, and I had Dr. Nasir and Dr. Blaha in mind for that. C also stands for cigarettes, never too late to quit, start with motivational interviewing, pharmacotherapy next, nicotine replacement and prescription medicine. D, diabetes, screen high-risk individuals, lifestyle modification first, metformin next, and then one of the newer agents. Diet, what do you need to remember? Vegetables, fruit, nuts, legumes, whole grains, fish. Maybe those Dallas steakhouses may have to serve a little bit more fish if they follow these guidelines. And E stands for exercise, at least 150 minutes of moderate physical activity, and the importance of mobile health, trying to motivate people to keep up with the good exercise habits. So recently I had the pleasure of working with Dr. Mikos and Dr. McAvoy on a nice article that sort of summarized the cholesterol and primary prevention guidelines. And we put together this set of figures that I think you'll like. Promote a healthy lifestyle in everyone, shared decision-making with the family, with the patient and their family, measure risk factors and evaluate the patient's risk of ASCVD, remembering that that's really just an educated guess. And then determine the candidates for pharmacotherapy. We're definitely going to do it if they have atherosclerotic disease. We'll definitely do it if they have super high LDL. We'll most likely do it if they have diabetes. And then if they have a risk of at least 7.5%, then we're going to have that risk discussion. And personally, I don't order that many coronary artery calcium scans, but when I do, I find them very helpful. I think it's important. There's some patients that come to you that are already inclined not to go on medicine, and they want evidence to show that they should. And if people are already inclined to go on medicine, say, that's fine. Let's work on the hard stuff, which is the lifestyle modification. So at the AHA more than a year ago, I summed up by saying numbers matter. We now have thresholds rather than the targets that the Europeans had forth. We said lower LDL is better with proven therapies, high-intensity statin, at least a 50% drop. We brought back a threshold of 70 for the proven non-statins, ezetimibe first, Pcsk9 second. For people with FH or severe hyperlipidemia and LDL threshold, we wanted to get down below 100. And because of the Friedewald method limitations, think Martin Hopkins method. For the power of 0, remember that calcium is the best tiebreaker. If there's uncertainty, if they want to go on medication, if they're willing to do that, you don't need to do any other imaging. Personalization is very helpful in identifying a very low-risk group and a very high-risk group. Remember that selective use of coronary artery calcium is a decision aid and not a screening tool. So what are the things you want to remember when you leave here? The best tiebreaker to determine eligibility for statin therapy is a calcium scan. The risk estimator is an educated guess, and risk-enhancing factors can guide that risk discussion. But keep in mind that you can have 3 or more risk-enhancing factors, and in our MESA data, more than 40% of the people still were at extremely low risk. Numbers matter. LDL and non-HDL numbers are important to reassess and to assess adherence and the need for proven non-statin therapy. And now we have proven non-statin add-on options. The ESC guidelines favors lower LDL targets, and they've expanded the high-risk primary prevention eligibility. Well, I think the US guideline mirrors the clinical trial threshold concept for add-on therapy. So maybe providers will just like to remember that 55 or 70 number from the European guidelines, but from a cost-effectiveness point of view, I don't think that it's really justified the way the European guidelines were written. So I'd like to end up with this slide, a great creation of Dr. Mikos, Life Simple 7, and this is really the ABC approach. Remember trying to have more of your plates look like this rather than those at the Dallas steakhouse or those Houston steakhouses, and it was truly an honor and a pleasure to come to Houston. So thank you very much for your attention. Happy to entertain questions, comments. And you get a prize if you ask the first question. Looks like Dr. Levine gets the prize.
Marcus, first, that was great. A whole bunch of guidelines that made it very simple for us. I think this came up during the presentation or during discussions, and one person had asked is, if you have a CAC of 0, How long a warranty is that? In other words, what is the best guess when you should get another CAC, if ever again?
So great question, Dr. Levine wanted to know about the warranty period for zero coronary calcium. And Dr. Nasir, Dr. Blaha have published on this and also have another paper in the works that I think will clarify this a lot. But in our guidelines, we said 5 years is a very good warranty period of time. We clearly want to emphasize that if you have no coronary calcium, you still want to work on risk factors. That's so very important because 5 years, 10 years, a relatively short period of time, most of us want to be in good health for another 20 or 30 years. So I think the guidelines say, you might consider another scan if there's still uncertainty about whether to go on a statin in 5 years. But I think with Khurram's help, you'll have a lot of clarification in the year 2020. Other questions, comments? Anything about the Texans, the Ravens, Patriots, anything like that? Dr. Nasir.
So Roger, as always, fantastic lecture. We've spoken a lot about the risk-enhancing factors and calcium scores. And in the prior guidelines and the European, they had placed significant emphasis on the carotid IMT. It seems to have fallen out of favor with the new ACC/HA guidelines. What's your thoughts regarding that?
So Dr. Nasir always brings up a great observation. The European guidelines neglected the power of coronary artery calcium to down-regulate risk. And it seemed that there were a number of people, the guideline authors, were much bigger fans of carotid ultrasound. And the US guidelines find that the carotid IMT predictive value is much more variable than we thought. The presence of carotid plaque could be a justification to use therapy. But the nice thing, if you have a middle-aged individual, that if you had no coronary calcium, you can be give much more reassurance that their risk over the next 10 years is exceedingly low. So that's another area of somewhat disagreement that I personally have with the European guidelines. But it'll be interesting to see how the field unfolds. Dr. Zogby.
Roger, pleasure having you here, and it's very well timed just before the holidays. I think this is...
So you won't have those kind of things serving at the holiday
right?
Christmas party, probably.
Going to the... if you have somebody with an LDL that is close to the range where it needs to be treated, and you have a CAC of 0, what do you do with these individuals? Do you repeat? I mean, obviously the concern there is for them to develop the disease and then you're at a different risk. Right. So that's one question for you. The other one is regarding the risk calculator. It omits other risks, right? So it doesn't give us the whole, and it doesn't give us a range, just gives it a certain number.
Correct.
So the question to you is, are there any modifications of this that are upcoming to include the other risks? And how much, what is the delta? What is the confidence limit of these?
So Dr. Zogby brings up some great points. I think I would look at the ASCVD risk estimator, again, as an educated guess, realizing that in Khurram and Mike Blaha's work, that in that range of 5 to 20%, half of those individuals had no coronary artery calcium and are extremely low risk over the next 10 years. So as you pointed out, it doesn't take into account dietary habits, lifestyle habits, doesn't really take into account triglycerides, doesn't take into account family history. We tried to get around that a little bit by putting these risk-enhancing factors in. But interestingly, you can have 3 risk-enhancing factors, and a good number of those folks are still at extremely low risk. So as Dr. Nasir always likes to say, there's a tremendous heterogeneity of risk, whether it's people who have LDLs in the 190 range or people in the 100 range. And personally, I think we can present things to our patients. We can say that their 10-year risk is based on the data is quite low, but some will want to say, well, doc, if it'll decrease my chance of developing atherosclerosis in the next 15 to 20 years, why don't we go ahead and start on the statin? I always emphasize that the most important thing for them to do long-term is going to be those lifestyle changes. So each and every visit, I'm sure the same with Dr. Jones over the years when he's seen patients with high lipids, is we spend so much time on the dietary and exercise things, and and Dr. Levine has tried to emphasize this in a lot of his writings too. The lifestyle is so very important. That cholesterol is only one part of that ABCDE framework, and I think that's really important. So the other offshoot of your question is the fact that we're only looking again at that heart attack and stroke, but many people would say, Doc, I'd like to prevent that chronic atrial fibrillation. Doc, I'd like to prevent that heart failure that my uncle or aunt had. Doc, I want to prevent those multi-vessel bypass PCI procedures. And those things we have to remember are not in the ASCVD risk estimate. So thanks for that great question. In the back, yes, sir.
Yeah, thank you for the great talk. I'd like to see what your thoughts are on these non-invasive endothelial function tests that have come out, the VENDIS and the EndoPAT, in predicting risk. They're very easy office-based tests. Are there any recommendations or guidelines that you think we should be using those?
So thank you for the question. So our committee did look at some of those types of tests, and like EndoPAT and others measure of endothelial function, and we didn't think at the time that the data was strong enough to say that they clearly improved risk assessment. That doesn't mean that maybe in the next year or two there won't be other publications. I personally think that if there's a way to motivate patient, we should try to do it, but I haven't found that much of a help in when patients have had that test and to get them extra motivated. Because if I can't get them extra motivated by saying your BMI is 29 and your exercise routine is once a week for 15 minutes, I try to motivate them through that way. But we do use some of those techniques in some of our research studies. So stay tuned, and maybe a year or two from now, we'll have a little bit more information. Any other questions? Remember, Texans, Patriots, Ravens, I know a lot about that. Glenn.
Roger, it's probably covered in your prevention guidelines, but I've read them so many times during development, I've probably become numb and forgot it. So for aspirin has clearly fallen out of favor in general for primary prevention, but we clearly still use it in people who have had MIs and plaque rupture. But there's also a lot of gray area patients. The patient who has maybe mild angina, but we haven't cathed, or had a mild nuclear stress test that's positive and we're treating, or was sent to cath for chest pain and who has 20 or 30% plaques. They're sort of in this gray area between primary and secondary prevention. Can you summarize your thoughts on these gray area people? And again, you may have covered it in prevention, but I'm just numb from reading it so many times.
So Dr. Levine brings up a great point. I think, in individuals like we have up here who are smokers, we certainly advocate strong consideration of aspirin. Maybe people with multiple family members who have had early heart disease, people who have quite high lipids and we can't bring them down with statin therapy, people with maybe those 20, 30% narrowings or moderate coronary artery calcium, or people who have at least a 20% 10-year risk of ASCVD. At least personally, those are the people who I would consider. And we have to remember that there was a modest benefit of about 12% in the ASCEND trial with diabetics. It's just that it was counterbalanced by that increased risk of GI bleeding. So there are quite a number of physicians who've had patients who've been on daily aspirin and they're trying to digest what to do, and a number of them who are very smart say, well, maybe I'll cut it back from 7 days a week to 3 or 4 days a week, and maybe I'll make sure they take it with food in their stomach. We don't have great data that that's going to be as helpful as daily aspirin, but I think that's a reasonable compromise, and we'll see when Dr. Nasir and others head up future guideline committees how he'll phrase that. But I think the judgment is also very important. Maybe time for one more question, or anyone else have one that wants to talk about things? So in essence, just remember, ABCDs of prevention. So much of what we've done now about assessment of cardiovascular risk is due to Dr. Nasir, Dr. Blaha, Dr. Budoff, and Dr. Mikos, Dr. Joshi, and others over the years have collaborated with Khurram. And I think we owe a debt of gratitude to Houston Methodist for their leadership in this area. So thank you very much for your attention.